Hello, and welcome to DCIS 101. I'm Dr. Frankie Holmes. I'm a breast medical oncologist. That means I use medicines to treat breast cancer. After practicing for 15 years at MD Anderson, I joined Texas Oncology in 1998, where I am today. I am so lucky to have a terrific team of women working with me. Dr. Michelina Cairo, who is my partner, and Janice Tran, our devoted, dedicated nurse practitioner. If you are coming here to visit, either Dr. Cairo or I will be with you very shortly. If you are here because this diagnosis has affected you or someone you care about, I'm sorry. I hope, however, that this information may answer some of your questions and quell some of your fears. Now, before we get started, I want to address a question that was prominently out in the media about 2 years ago and which still keeps coming up, and that is DCIS really cancer? Some people think of DCIS as cancer light, and I'm in that crowd. Some say DCIS is not a cancer at all. Well, let's just have a few thoughts. The first thing is DCIS is a very heterogeneous disease. Heterogeneous means that not all DCIS tumors are the same. So a good way to think about heterogeneous is to think of all the people at a major airport, different ages, races, socioeconomic status, different occupations. That's a good idea of what heterogeneous means. So when we think about a disease that is so heterogeneous, sometimes it's difficult to generalize. Some tumors are not very aggressive, but others are. And the next bullet relates to our friend here on the right. When scientists studied the genes inside a DCIS cancer cell, they found that many of the genes that were present in a cancer cell, that is the invasive cancer cells, are also present in the DCIS cells. So clearly, these DCIS cells have a cancer blueprint. And so this reminds me of an amazing study that was reported when scientists looked at the DNA of gorillas. Boy, that gorilla seems quite different from us, but in fact, the DNA he has is 97% the same as our DNA. We are only 3% different. But what a difference that 3% makes. So DCIS is curable, but we do need to take it seriously. I want you to know about DCIS if that's comfortable for you. Now, I know some patients just want to know what to do and they don't want to know all the facts because it makes them anxious. And if that's the case with you, then this isn't the right thing for you to listen to, and we'll talk when I see you. But for most people, fear of the unknown is difficult. And in this knowledge economy that we have, we know that knowledge is power. Power gives us back some of the control. It seems that this sudden diagnosis just thrusts in our face. I'm always reminded of that speech that our President Roosevelt gave during the desperate times of the Great Depression when he talked about the 4 freedoms and freedom from fear. I hope the knowledge that we get from this little audio tape and from our visit will help you become fearless. I want you to know that DCIS is not a cancer that kills, not a cancer that needs chemotherapy. So let's learn a few things. The first is a good analogy for how the breast works is like an oil well. And we in Texas are pretty familiar with oil wells. There's 2 major parts. The first is the oil. And in the breast, that would correspond to the lobules that make the milk. And you see these here with the blue arrow pointing to these grape-like structures of the breast that is cross-sectioned in this cartoon diagram. The second part of the oil well is the pipeline. And in the breast, that corresponds to the ducts that are shown with the pink arrow. And in the cut out blow up below, you see what a duct looks like. It's one layer of cells that are all alike, arranged in a circle. It is the ducts that cause 90% of the problems in the breast. Just like all other parts of our body, the cells in the ducts wear out and have to be replaced. The body has a very ingenious way of doing that by using estrogen. Estrogen is like a fertilizer for those cells. So when one cell dies, 1 unit of estrogen will cause the cell to replace itself. And this is part of the normal cycle. When we get older and don't need to breastfeed and aren't having periods, we don't have to replace the cells in the breast as much, and the breast tissue atrophies. So what goes wrong to cause DCIS? A mutation. A mutation makes the cells super sensitive to estrogen. Imagine when you get a sunburn, and normally one of your friends always sees you and gives you a little pat on the back or a hug, and today you have a sunburn and ouch, it hurts. Hey, but I was just giving you a hug like always. I know, but I have a sunburn now and my skin is super sensitive. And this is what happens in the breast ducts. When the cells have a mutation, it makes them super sensitive to estrogen. So when one cell dies and there's a need for estrogen to cause replacement, that 1 unit of estrogen acts on the cells that are super sensitive like perhaps 10 or 100 times as much. And it causes the cells to grow and divide too much, and it starts making too many cells. And this is what we call ductal hyperplasia. These cells look normal, they are just too many. We call this ductal, duct cells, hyper, too many, plasia. So if you can imagine, these cells are growing and dividing so fast, and they are now even making a few more mutations, and there's pressure to even grow and divide more quickly. Okay, start making more cells. Well, I can't. I haven't finished making this cell. Stop anyway and make a new cell. That's basically what's happening in the breast. And now the cells start to look abnormal. And we call this atypia. Atypical because the cells look abnormal. Hyper because there's too many. Plasia cells. If this process keeps on going, cells keep on dividing, more mistakes accumulate, and then cells turn into ductal cancer in situ. On this slide, we see a summation of the entire process from the anatomy of the breast, showing the ducts and the lobules, the normal duct, the duct with hyperplasia with too many cells that all look perfectly normal, and then the atypia, and then the line is crossed to form ductal cancer in situ. You see a white arrow showing that ductal cancer in situ may, but does not necessarily, have to progress to invasive cancer. Now, let's learn how we judge the aggressiveness of this very heterogeneous disease we call ductal cancer in situ. We have classification schemes. And again, those of us here in the Gulf Coast know all about classification schemes because in hurricane season, we are always listening for the category of these tropical depressions to help us determine how much damage could be caused and what we need to prepare for it. DCIS also has a classification scheme, and there are 4 factors that help us determine treatment. The first is grade. Grade is determined by the microscopic appearance of the tumor. There are 3 grades. Unlike being in school, the lower the grade, the better. Grade 1 is the least aggressive. These cells look more like normal tissue. So if any of you are in my generation, you will remember Gomer Pyle. He was a cop who was not very aggressive and would never be accused of police brutality. This is a grade 1. The second is grade 2, that's intermediate. And so my analogy is G.I. Joe. Grade 3 is the most aggressive, and the analogy I use is the late Osama bin Laden. The second is the proliferative rate, that is, how fast or how many of the cells are growing. And this is related to grade. It's like an internal validation. Grade 1 tumors have a low proliferative rate. Grade 3 tumors have a high proliferative rate. The third factor is the hormone receptor status. Do these tumors still need estrogen, which we term ER for estrogen receptor, and or progesterone, we call PR, to grow? It's better for the cells to still depend on hormones because that gives us a way of potentially controlling them. Some DCIS tumors, however, may mutate and not need hormones, and these are different. The last factor is the size of the DCIS. Is it just in one area or is it very extensive? On this next slide, we talk about the main goals of treatment. The first goal, which is the goal of your surgeon, is to remove all of the tissue with a clear rim of normal tissue. This is treating the location of the tumor, and we call this local treatment. This rim of normal tissue we call margin, and our goal is a negative margin, no tumor. If you look on the left, you see the picture of a cartoon with the cancer in the middle and the normal tissue around. My analogy for this is to think of a sunny side up egg. The yolk's in the middle and all the white is around it. The second goal is to prevent tumor coming back in that breast if the entire breast is not removed. And this is another aspect of local treatment. And here we have a radiation oncologist, and that is his or her job to give radiation to the remaining breast tissue because there could always be cells that we can't see but are microscopically present. Additionally, the goal of the medical oncologist is, if the tumor is ER or PR positive, that is, if it still requires hormones for growth, to give an anti-hormone treatment to help stunt or prevent its growth. And then the third goal, which is also the goal of the medical oncologist, is to prevent a new tumor from developing in any remaining breast tissue. Remember, the breast, like the lungs and the kidneys, is a paired organ. So the breasts are somewhat like sisters, and what happens to one sister has a chance of happening to the other. It's not very much. It's only about 0.5% a year, but that's a little bit higher than a patient who did not have breast cancer. And giving anti-hormone treatment to decrease the estrogen stimulation of cells that may have mutated has been shown to decrease the chances of developing a cancer in the opposite breast, either DCIS or invasive cancer. On the next slide, I'm making allusion to what we already talked about. Breast cancer care is a team sport, in a sense. It requires teamwork. The diagnostic team is our breast imaging team, those mammographers, ultrasonographers, and also the pathology people. Those are the people in the back rooms that you never see. The therapy team, which is your medical oncologist, your surgeon, your radiation therapist. And then there is the rehabilitation survivorship team, the plastic surgeons, the oncofertility doctors, which parenthetically is not usually a big problem with DCIS because we aren't giving chemotherapy, which is the cause of fertility problems. The physical and occupational therapy folks, and we'll talk a little bit about that at the end. Nutrition, and of course your primary and subspecialty care. If you have diabetes or high blood pressure, thyroid problems, those folks still continue to play a key and critical role in your care. And on the next slide, you see it does take a village to give the high level of care that we want every patient to have. It is all of these specialists and subspecialists and generalists working together, all with one aim, to give you the very best outcome possible. Now, let's look at local treatment on the next slide. We have two types of local therapy, surgery and radiation. So let's look at surgery. There is lumpectomy, which removes only the tumor with a clear rim of normal tissue and preserves remaining breast tissue. Generally, we do not need to check the lymph nodes, but as we indicated before, leaving breast tissue present that could harbor microscopic deposits of the Dcis means that we need to give treatment to the entire remaining breast tissue. The other option is mastectomy, with or without reconstruction. If a patient decides to have immediate reconstruction, sometimes we check a few lymph nodes by the sentinel lymph node biopsy procedure that removes just a few lymph nodes. Radiation is not needed in this situation unless there is some unexpected finding of invasive disease. So on the next slide, we review a question that comes up very frequently. Is more surgery better? Should I really just have a mastectomy? Or is lumpectomy just as effective? Well, unlike in invasive breast cancer, there are no head-to-head trials comparing mastectomy to lumpectomy. But the thought leaders, the scientists, the thinkers that I showed on that very first slide have extrapolated or projected from the trials of lumpectomy in invasive disease, comparing lumpectomy and radiation to mastectomy, and designed some trials. For ductal cancer in situ, mastectomy removes all the breast tissue, so the risk of the tumor coming back is very small, maybe 1 to 3% over a lifetime. But this is an aggressive treatment for a tumor that doesn't kill patients. So let's look at the statistics. How did mastectomy compare to lumpectomy and radiation in some of the early trials that were done? There are slight differences in the chance of the tumor coming back in the breast because, of course, there's breast tissue compared to a mastectomy. But there isn't a difference in how long people lived or if the breast cancer came back. So in this famous textbook by Dr. Harris, Lipman, and Morrow, and Osborne, who actually is in practice still at Baylor College of Medicine in Houston, they looked at a series of over 1,500 mastectomy patients and followed them for almost 8 years, and they found that about 1.4% recurred. In the 1980s, there were 4 trials of radiation after lumpectomy compared to lumpectomy only. Now, the things that scientists and oncologists look at in these clinical trials are how many patients were in the study, because you have to have enough patients to make sure you're getting an accurate result. You know, you can flip a coin 3 or 4 times and you might come up with heads every time, but you know that if you flipped 400 times, you would not come up with 400 heads. And so that's why we need a large enough sample size. The second thing is we need to follow patients for a long time to make sure that we're not just seeing something in the beginning that looks very good, but over time would not hold up. So longer follow-ups are better. And in these trials here, the B17 was one of the ones that was critical in the United States and which has the longest follow-up of over 17 years. You can see in the pink square that there was no difference in the survival rate of patients who's had treatment with lumpectomy versus lumpectomy with radiation. We're all somewhere in the range of 97 to 98%. In the next slide, we look at the results of one of the platinum standard reviewing organizations in our breast cancer community. And this is called the Early Breast Cancer Trialists Collaborative Group. And even the initials are still a mouthful, EBCTCG. But these analyses are done at Oxford, and so many of us call them the Oxford Overviews. So this group looked at all of the women in those studies previously discussed on the prior slide. It was about 3,700 women, and they looked at the difference between doing just breast-conserving surgery, that is lumpectomy, versus breast-conserving surgery and radiation therapy, because this was the first step in trying to figure out what is the least or the most amount of surgery or treatment that was needed to give the best outcome. And they found that at 10 years, if you just had the lump taken out, about 1 in 4 patients would have their tumor come back. But if you had the lump taken out and then got radiation, that was improved to about 1 in 8. And the chances of the tumor coming back per year were about 1.3%. And they had follow-up for at least 10 years overall, and there was no effect on death from other causes. And there was no effect on heart disease from the patients who got radiation. And this has also been raised as a concern. Gee, I don't want radiation. My tumor's on the left side. I don't want to get a heart attack from this. And they found that was not the case. So the next step was to look at the effect of tamoxifen given after radiation therapy. And they showed that tamoxifen further decreases the chances of tumor coming back. So in these two panels, the panel on the left, again, recapitulates what we saw in the previous slide. For patients who had breast-conserving surgery, which is lumpectomy, about 1 in 4 had the tumor come back, and those who had breast-conserving surgery with radiation, about 1 in 8 had the tumor come back. Now, if we look on the right panel, the women who had tamoxifen, they had an improved outcome even if they didn't have radiation. So instead of 28.8% of the patients having a recurrence, it was only 18.3%. So we went from about 1 in 4 to about 1 in 6. And the patients who got radiation had an additional decrease in their chances of recurrence, going from about 1 in 8 to 1 in 11. That equates to a risk of recurrence per year of 0.9%. Now, on the next slide, we note that if you are on menopause, there is another type of anti-hormone that is even more effective than tamoxifen, and these are the aromatase inhibitors. These were discovered in the 1980s, and all of the studies were done in the 1990s. And in the invasive cancer studies, there were many head-to-head comparisons of the aromatase inhibitors to tamoxifen, and these were shown to be about 20% more effective than tamoxifen. There are 3 aromatase inhibitor medicines that we are presently using in the United States: anastrozole, letrozole, and exemestane. They are now mostly off patent, so their previous trade names are not used as often, but you may have heard Arimidex, which is anastrozole, Famara, which is letrozole, and Aromacin, which is exemestane. When these two were compared in ductal carcinoma, the results showed that anastrozole in DCIS, like in invasive cancer, was more effective. And a large study in over 3,000 patients was reported just this past year at the San Antonio Breast Cancer Meeting in December of 2015. This slide summarizes the results of that trial and also shows you some of my personal heroes. Dr. Bernie Fisher, the photo in the middle, was the very visionary surgeon who realized women did not have to have a radical mastectomy to survive breast cancer, that maybe we could do lumpectomy and check the lymph nodes and give radiation. In today's time, when we have reconstruction and bilateral mastectomies, the magnitude of his contribution is not so apparent. In the days when he was doing these studies, radical mastectomies were done, and these were such debilitating procedures. Patients were in the hospital for a week. And one of his colleagues was Dr. Norman Wallmark, who was also very passionate working with Dr. Fisher. This trial was reported by Dr. Richard Margulies, who is one of the original group of those physicians in the NSABP, the National Surgical Adjuvant Breast and Bowel Project, which is now called NRG. And this trial was the B35 trial. This study was done over about 3 years, from 2003 to 2006, and so it was reported in 2015, so that gave us 9 good years of follow-up for the average patient. That meant that half of the patients were less than 9 years and half were longer than 9 years. And this is what we describe as the median, not really the average, it is the median. But this is important because it's long enough to get an accurate read-off. The aim of this was to measure what is the time free of breast cancer at 10 years. And it was found that anastrozole was better, about 94% compared to tamoxifan's 89%. An interesting finding of this was that in younger women younger than 60, anastrozole was better, about 95% compared to 88%. Now, 2 things here. Anastrozole was clearly better, but look how good women are doing anyways. On tamoxifen, 88% of the patients at 10 years are doing very well. The other part that was very interesting is that in women who were over 60, both medicines were the same. Anastrozole and tamoxifen were about 90 to 92%. The other aspect that we always look at in these trials in which anti-hormones are given is there any effect in the opposite breast? Because remember, the breasts are sisters, and what happened to one sister could happen to the other. In DCIS, the chances of a cancer developing in the opposite breast is about 0.5% a year. The patients who were treated with anastrozole had a better outcome, but the numbers were small. And remember, you need very large numbers to make definitive conclusions. But what they showed was that in the 1,500 patients whose tumors came back, only 20 patients who were taking anastrozole had the tumor come back in the other breast, as opposed to 36 in the tamoxifen patients. And when I say tumor come back, I mean a new tumor develop, because DCIS does not spread or metastasize from one breast to the other. These are brand new cancers developing. In the last 2 bullets, it's important to realize 2 things. First is the survival at 10 years was the same. That is, DCIS, unlike invasive cancer, is not a cancer that shortens life. So unlike our invasive cancer studies where we're checking to see, does this treatment prevent patients from dying? DCIS doesn't cause patients to die of breast cancer. So survival is not affected. And that's important to know if, for whatever reason, it doesn't seem possible to take an anti-hormone treatment. Patients need to know that this is not going to cause them to die sooner of breast cancer. And finally, the differences between anastrozole and tamoxifen in terms of side effects are different. And we will go into them at the time we discuss them with you. But for patients who are older, because the 2 are very similar, it means that older patients can have a choice of either one of these medicines without feeling they are compromising their outcome. Anastrozole is associated with more joint aches, whereas tamoxifen has a slightly increased risk of blood clots, and if a patient has a uterus, possibly an increase in the risk of uterus cancer. But these side effects that are severe, or could be severe with tamoxifen, have a very low incidence. So, as with everything else in life, it requires a risk-benefit analysis and some judgment. So, let's summarize here. What are the usual procedures after DCIS is diagnosed? First, we need to establish your oncology team. Your surgeon, your medical oncologist, your radiation oncologist, possibly a plastic surgeon, of course, the physical therapy team, and of course, to stay in contact with your primary care and other subspecialists. The second is to review the pathology report and the images to determine how extensive is the tumor. Is it possible to do lumpectomy? Are there other concerns, such as do you have lupus and maybe radiation is the best thing for a patient with lupus? Is the tumor hormone positive? Will it benefit from anti-hormone treatment? The third thing, get all of your questions answered so that you can decide about the type of surgery. And you don't have to do this by yourself. There are references on my website, breastcancer.com, that have websites that are vetted by the leaders in breast oncology. And of course, all of the doctors who are caring for you, your radiation oncologist, your surgeon, your medical oncologist, are there to help you make the very best decision and to feel good about it. As mentioned before, we will consult with other specialists to make sure you have the best outcome: prehabilitation, plastic surgery, genetics, if there's a family history. Finally, you'll have the surgery, and then we will review the pathology report with your team, and it will be obvious what the next steps need to be. So, now that we have covered a lot about DCIS, let me just share a few other thoughts about patients diagnosed with breast cancer. Many patients tell us that once they've been diagnosed with breast cancer, whether invasive or DCIS, they become the local expert in their circle, and people start asking them questions. So let me share a few thoughts based on patients, most of whom had invasive cancer, not this highly curable cancer DCIS. But still, much of this information is very applicable. Fitness, body mass index, nutrition. If you are already dealing with the DCIS issues, you could skip this part and get back to it later. And if you've gotten this far, congratulations, you have done very well. So, what are some of the discoveries about our daily life or lifestyle that can help us with breast cancer? The first one, is fitness important in breast cancer? Unequivocally, yes. Obesity and inactivity are risk factors for the development of breast cancer. And if a patient has breast cancer and they have obesity and inactivity, those patients have an increased risk of the tumor coming back and dying from that tumor. Also, we know that patients who are obese and who are not active may have a decreased or no response to some of our treatments. But the very good news about all these is that they are what we call reversible. That means changeable, fixable. The catch-22 is, however, that many patients are already not in the best physical shape when they are diagnosed, and so we have to play catch-up. So this study by Dr. Marianne Ewerts was reported in 2011, and she's a Danish researcher, and she looked at almost 19,000 patients with breast cancer. You know, in Denmark and the Scandinavian countries, everybody has a unique number and all of their health problems are followed. This is the socialized medicine approach. So they can look back and see trends in their population. So they looked back at patients from 1977 to 1996, all of whom were followed at least 10 years for recurrence of the breast cancer and 30 years to determine if they died of breast cancer. And in particular, she looked at the patients in the brown curve at the top of that array of lines who had a body mass index of greater than 30. So body mass index, you can Google it and you can find your own, but it is a mathematical calculation of your height and your weight. And no measurement is perfect, but this is one that is widely used. 19 to 24 is normal. 25 to 30 is overweight, and over 30 is considered obesity. So if you look at the brown curve, it showed that the patients who had a body mass index of greater than 30 had an increased risk of recurrence in brown compared to those patients who had a normal body mass index. There was almost a 50% increase. And then if you look at the panel on the lower right, it showed that there was almost a 40% increase in the risk of death between those patients in the brown and in the gray. This is an easily fixable thing. The next slide explains some of the reasons why these patients who are heavy have an increased risk of recurrence and death. And that is because the presence of excessive fat, it's almost like that creature in Alien that lived inside the body, and it caused significant effects on the body. Fat becomes an organ of its own that secretes factors, just like the pancreas secretes insulin. These factors cause inflammation. Inflammation is what happens when you get the flu and you feel like somebody beat you with a bat. It's due to the release of these cytokines, which are factors from the immune system. Also, inflammation causes growth of blood vessels. And of course, tumor cells need blood vessels to feed them. There are many other things that fat cells, by causing this condition of inflammation, can generate. And these are all helpful to the growth of cancers. So on the next slide, Dr. Michael Natt, who is one, again, of the major thought leaders of breast cancer and who is from Australia, looked at a group of patients to determine the effect of this drug that at that time was quite new, anastrozole, given after 5 years of tamoxifen for patients with invasive cancer. At that time, it wasn't known that 10 years of tamoxifen would be better than 5, and so patients were just treated with 5 years of tamoxifen. Also, anastrozole, or the aromatase inhibitors, were not used as much in the very beginning until their undoubted improved results were shown. So in this group of patients, half of the patients just took 5 years of tamoxifen and then stopped, and the other half took 5 years of tamoxifen and then took anastrozole. Anastrozole is an aromatase inhibitor, and it blocks the formation of estrogen from fat cells and also inside the breast cancer cell itself. So we see here that he looked at a subset of these over 1,000 patients. On the next slide, we see two panels. On the top panel were the patients who had a normal body mass index, and we can see the disease-free survival, which is how long did they live before the cancer came back. The anastrozole, with the yellow box ANA, patients as compared to the control patients who did not take anything, did much better. Then if you look below on the high body mass index patients, there was no difference in the anastrozole and the control. And so Dr. Natt and others concluded that the patients who had a high body mass index had too much aromatase for the usual dose of the medicine to block. And so the patients were still making estrogen, which was feeding their cancer. This is something we can easily fix. The next slide shows us that physical fitness is not a universal characteristic of most of us, and that many patients who are diagnosed with breast cancer are not in the best fitness condition when they are diagnosed, which means that they will not be in the best fitness condition when they finish their treatment. So Dr. Kathy Miller is another one of the bright lights in breast cancer who's at Indiana University. And what she wanted to do was to figure out in patients who get treatment, what was the effect of that on their fitness, and after they finished their treatment, how quickly did they get back to normal? And so, as any good researcher, she defined how she was going to follow this by looking at the body mass index, what was the body muscle fat composition, and a number of other factors. She looked at patients who had stage 0, which is DCIS, all the way up to stage 3 breast cancer. 23 patients had chemotherapy and or with or without anti-hormone treatment. 14 had only anti-hormone treatment, and 6 patients had surgery with or without radiation. So these patients who had surgery and radiation they had the least disruption to their health. And some of the important things that they looked at was what was the amount of oxygen consumed by doing certain standardized tasks. If you are very fit, just like if your car is functioning fully and up to date, you need less gas to get the most mileage. If you are very fit, you need less oxygen to do tasks than people who are not fit. The other thing they compared this to was to look at the oxygen consumption based on total body fatness and lean muscle. And on the next slide, you see the peak power, which is the oxygen consumption in the first half of that panel. And you see a green line, and that green line is where all of us should be. But to her amazement, she found that at baseline, the patients who took chemotherapy in the pinkish red, or the patients who only got hormone therapy, which is in the blue, they were equally poorly fit. They were at least half as fit as they ought to be. And as time went on at 6 months and 12 months, they didn't get better. So many patients are already deconditioned at diagnosis, and you can see there is a slight decrease in those numbers at 6 months and 12 months. Not only did the patients not get better, but they were a little bit worse when they finished treatment. So patients need help getting up to where they should be in terms of fitness right from the get-go. And after treatment, we need to keep working on this. And on the next slide, I'm showing that's why I send all of my patients to prehabilitation before any treatment. I don't want just to rehabilitate, I want to prehabilitate. The next slide answers a question that many patients have. It is not a question that DCIS patients will have, because there is not normally a need to check the lymph nodes in a patient with DCIS. But one of the concerns, if patients have had lymph nodes removed from their surgery arm, is whether or not they can ever have any medical procedures done on that arm, such as blood pressure or blood tests. And there was a very precise study done at Massachusetts General Hospital that said all of these types of procedures did not increase the chances of arm swelling, which we call lymphedema. It was only injury to the arm that increased the chances of swelling. So this slide shows the details of that study. There were about 700 patients, and 560 of them had surgery on one breast, and 160 had surgery on both breasts. The type of breast surgery was equally divided between lumpectomy and mastectomy. 2/3 of the patients had lymph nodes removed by the sentinel procedure, so that means only a small number of lymph nodes, generally 1 to 6. About 18%, or about 1 in 5, had the full axillary dissection. And there were 14%, 1 in 7, who didn't have any axillary surgery. So those were probably the DCIS patients. So they have this really neat machine, which you see on the left-hand panel, that looks like 2 sets of squares, one larger and one smaller. That larger square moves, as you can see, up and down, and it has lasers that measure the arm at each of these time points and reconstruct the circumference at each time point. So it provides a very accurate way of looking at the volume of the arm. And you can see down below in those 2 panels what we're hoping not to get. And they looked at these 710 patients to see who got swelling in that arm. And you can see that there was a slight amount of swelling, 1+, in red with an injection, blood pressure, but this was not felt to be statistically significant. The only thing that was found to be statistically significant was trauma to that arm, and that was highly significant. On the right-hand side of the big red bar graph, You can also see airplane flights. Now, most physical therapists will recommend that patients get a sleeve for their mastectomy arm if they travel, and you can see perhaps there was some slight increase. So it is not unreasonable, but this is not a major cause of lymphedema. The major cause is trauma. And then one other factor that really was not addressed in this study is weight gain. Weight gain definitely causes an increase in lymphedema, and it's yet one other reason that we want to make sure our patients are fit. And finally, on this last slide, I want to go back to the very first slide with pictures of my heroes, Dr. Fisher, Dr. Woolmark, and many others who were passionately involved in trying to help prevent or treat with the least amount of side effects. So we want to promise this dear little one that clinical research trials are going on today so that you don't have to get breast cancer when you finally do grow boobs. And I will just put in my own personal plea here. If you have an opportunity to be a part of a clinical research trial, please think very long and hard about participating in that trial. Only 4% of patients in the United States participate in clinical trials. So that means these 4% of patients are the ones who carry the weight of moving the breast cancer field forward. A journey of 1,000 miles begins with a single step, and you could be one of those important steps. So thank you, and the very best to you if you've just been diagnosed with DCIS.